Welcome back to the Four Eyes Optometry podcast, brought to you by YoungOD Connect. We give you a clear view into the new grad and young OD world across Canada and the US. And we are your hosts. I'm Dr. Amrit Bilku.
And I'm Dr. Deepan Kaur. And today we are talking to Dr. Kambiz Silani about the importance of OD to OD referrals when it comes to dry eye management in patient care and his treatment approach to ocular surface disease with the various devices and technologies his practice has to offer.
And we're excited to have him on. Dr. Silani is the Chief Clinical Director of Beverly Hills Optometry. And 10 years ago, in 2013, he opened the Advanced Dry Eye Center within the practice. So Dr. Silani is well known for his very high-tech practice in Beverly Hills. He utilizes and adopts office-based devices to properly diagnose and treat patients for all types of ocular surface diseases. And most recently, he was ranked 16th in the US on Newsweek's 2022 and 2023 list of best eye doctors in America, as well as one of LA's top doctors for 2022 and 2023. So without further ado, let's get into this exciting conversation.
So Dr. Silani, for those who do not know you already, can you tell us a little bit about yourself and how did your specialty dry eye practice come to life?
Certainly. So I'm a SoCal native, grew up in Beverly Hills, went to UCLA, Western University for optometry school. In fact, this month, very appropriate, we are celebrating our 10-year anniversary of starting the dry eye practice, Advanced Dry Eye Center. So very proud.
Congratulations.
Congratulations. Yeah.
That's huge.
Just another fun note, we have our first newborn on the way, a baby boy.
Yes.
Oh, that's right. Yeah.
Congratulations.
That's even the bigger congratulations.
So,
oh my God.
Really excited that that's on the way. We had spent our this first decade just kind of building the practice and getting it on the right track. And really amazing that we've been featured and recognized on the Doctor Show and in Fox News and NBC News and publications in optometry and ophthalmology, Review of Optometry, Modern Optometry, Eyes on Eye Care, Ophthalmology 360, which was kind of cool.
Nice.
And just consulting and speaking and thought leader for a lot of tech and eye care companies along the road. I really got invested and interested in dry eye because it's something that I've dealt with. So I'm very passionate about dry eye because I've had it for nearly 2 decades. I also have an autoimmune condition that I've been managing well over the years, but the dry eye was a struggle in the first decade because it was just pharmaceuticals at the time, right?
Yeah.
Restasis and steroid drops and over-the-counters. And this most recent decade has been really, really exciting with the advent of a lot of technologies that we'll talk about. And in fact, the first one that I was introduced to was at a conference by the founder, who's an ophthalmologist and inventor, Dr. Reinerson, who treated me with BlephX. And I had tremendous relief after that whole session. And I said, hey, this is kind of cool. Let's see where we can take this, and started to look into the literature and number of articles. And that was the first device we brought in. And here we are 10 years later. I believe we have just under 15 treatments that we do in the office.
Oh, wow.
Oh, wow.
Can you name all of them off the top of your head?
So
in 10 seconds?
Yeah, I'm happy to. We created a great link that I'm happy to share where it breaks down, and it's great. We share it with patients, but it's also kind of great to share with colleagues who refer to us, which is what we're going to get into, of course. And we're open for colleagues to share it because it has hyperlinks that go over things like IPL and what it means and what it's about, and videos, as well as radio frequency and tear care and ILUX, dilation irrigation, Procara, scleral lenses, probing, BlephX, Zest bisocular, low-level light therapy. So yeah, all the things.
Wow. Yeah, that's great because for we'll get into it too, but for someone like me who does not offer advanced dry eye treatments, I usually just refer, for advanced treatments, quote unquote, but I never really understand, what exact treatment is offering what care and managing what sort of dry eye condition. So yeah, it's always nice to have those kind of flow charts or little reference sheets So that's a great idea to give that to not just the patients, but then the people that you want the referrals from, because then they know exactly what box to check.
And I love that, where referring optometrists or ophthalmologists send the patient for a certain procedure. And sometimes we may pivot, right?
Yeah.
The patient may not be a candidate for something. If we get a patient with a small fissure size, right, and they're referred for late lipoflow, we might pivot, or they're claustrophobic, we might pivot from lipoflow with big applicators to something like tear care or eyelets. And same idea when you're referring to refractive surgery. You might say, hey, this patient is great for LASIK or PRK, but they're on the border. And then the surgeon might say, I think ICL is a better option. We always respect and appreciate what the patient that's referred over, the doctor who refers them, as well as the recommendation that they've given.
Awesome. Now that we're on that topic of referrals, let's get right into it, because there are ODs like myself who are more limited to hygiene, artificial tears, and hot compresses. So more of those home remedies and, off the shelf sort of products. And then there's ODs like Deepon on here as well, who works in a dry eye office that has more of those advanced treatment options. So how would you advise the ODs like myself who don't have those advanced options? What would you say to me to not convince, but to encourage me to offer those opportunities for my patients? What are the benefits of me referring my patients to someone like Deepon, another OD who has those more advanced dry eye options?
Yeah, so a few things. One is, I love that you have products in the practice that you're recommending to patients, right? But even on that level, we have some doctors who are still just recommending things like baby shampoo, right? So we want to, if you're going to be offering office-based treatments,
Yes.
offering the best, they're still recommending just pick something out over the counter. Whereas we want preservative-free eye drops. We want specific type of compresses. We want specific type of omega-3s, as opposed to just saying, just pick something from Costco or the Kirkland brand. Now, say the patients don't respond to those, or they're a little more advanced, that's when you want to start thinking about referring to Deepon or a center that's a little more advanced that can offer more hands-on care. And I think the advantage there is that you're strengthening the patient relationship, right? So if they're having an issue and it's not being addressed and they're coming back and they're continuing to complain, and the referring doctor isn't giving them the solution, they're going to go around you. They're going to find an option. So if they come in and they see you for myopia and you're just recommending glasses and contacts, and they've kind of hinted towards they want LASIK, or are there any other options, and you don't recommend a refractive surgeon, then they may go find one on their own, and you're not involved in that care, and you might lose that patient forever. So same thing when we're talking about dry eye. If you're not referring to an advanced dry eye center, that patient is seeing content on TikTok, on Instagram, listening to podcasts, and they're going to find a solution somewhere else, and you may not be involved in that, and you may lose that patient. So as an example, we have a very deep relationship with our referring optometrists, and we let them know, here's my cell phone, here's a doctor's cell phone number, or here's my cell phone number. If you're going to refer a patient over, please don't hesitate to let me know who that is. So we mark or earmark their file. We only take care of their dry eye, and we send them back for everything else. So we have a primary eye care office and an advanced dry eye center. So I only handle the advanced dry eye patients. And if that patient wasn't referred, we might send them to my primary eye care doctor to handle that side. Whereas if it comes from a general optometrist, we'll send them right back. In fact, that happened a few weeks ago where I texted the general optometrist and I said, hey, this patient's coming to see us for treatment. She's asking my team if she can also get a refraction done. She's saying that she's not able to get into your office for 2 weeks. Can we sort something out? Because I don't want to upset her. And they were able to fit her in and get her in for refraction. So we keep that relationship very sacred.
I was just going to comment on that part, because what you said was perfect. And I think a lot of ODs who have really encouraged OD to OD referrals really emphasize that. If they're offering a specialty service, regardless of what it is, that patient will only receive that specialty service. And then out of respect, they'll send that patient right back to the referring OD. And that's great, because, that makes us confident with, you're doing your job, I get to still do my job, and I still get to keep the relationship with that patient. What I always thought in my head, though, was, but what do you do and how do you handle the situation if the patient is very adamant that, they love your practice and they love your
Mhm.
staff and everything was great, and they really want to leave that other doctor to come to your practice. So what protocols do you put in place, and how do you kindly, say no and reject that patient? And do
Yeah.
you inform the OD that the patient is really wanting to leave them and come to you? It's really, I feel like it's such an awkward situation.
Yeah, and I
Or it
think
could
that's
be just like easier for the patient too, right? Like they're like, oh, you already do my dry eye services. Why
Yeah.
not just do everything else? It's just easier
Yeah.
for me to go to one location.
absolutely.
So
And
yeah.
for me, I let them know I don't do primary eye care.
Oh,
So
okay.
Okay.
that's the easy answer for me, is that
Yeah.
relationship is also very, so as I said, is very sacred. So the ethics and professionalism, if you send me a patient and I don't send them back for primary eye care or medical eye care, and I keep that patient, you're going to lose faith in me, right? That's
Mhm.
not the right way to do it. Just like, again, going back to, you go to see your retina specialist, they do a great job of fixing your whole retinal holes, and they keep you for refraction and eyewear and all those other things. That's really not going to work.
Oh
So
God, I'd cry. I don't want to be there.
yeah, right.
No kidding.
Well,
Yeah.
take care of my retina.
Yeah.
I'm going back to my fun general optometrist. What's interesting about my background that I mentioned earlier is that I'm also a second generation eye care specialist. My family was in the
Oh, yes.
optical world for over 6 decades, so 60
Oh,
years,
Wow.
and they still continue to do that side, but we don't do optical in our practice. So that's one of the big things that a lot of
Oh,
referring
okay.
doctors, referring optometrists, ophthalmologists like,
Mhm.
is that we focus primarily on medical eye care. We do specialty contact lenses and general contact lenses, but our main foundation at our practice is advanced dry eye treatments, and
Yeah.
specifically more of the modern treatments to address the root cause of the problem, and not so much more of the Band-Aid work and pharmaceuticals, over the counters. And we do lean into
Nice.
those from time to time for flare-ups for patients who aren't responding, or if we want a little bit more compliance at home. But primarily, we're just really doing a big job of taking care of what we can in the office and what's in our control, because
Yeah.
compliance can be tough with at home.
Yeah. I guess that makes it easier when you're a non-dispensing practice. Then
Yeah.
the general
right.
OD doesn't have, that issue of the patient continuing
Yeah.
care with you. I feel like
Yeah.
it's going to be more tough for you. Really have to define your relationship with the referring OD if you also are a primary care setting. Like
Mhm.
for Deepon has advanced dry eye services, but it is a general optometric clinic with an optical too.
And really reassuring the referring doctor that, hey, we're not here to steal your patients.
Yeah.
Yeah,
Okay.
Yeah.
definitely.
But
Just
if
an
they find
extra
us,
note to
yeah,
reassure you,
if
we're
they
not here just to
find us through
patient.
Google, we can't promise that, right? But if
Yeah, yeah.
they're sent over by you, then yes, we'll do our best. And the other important thing too, I think, is keeping the referring optometrist or ophthalmologist involved in the care.
Yeah.
That way they know what's happening. So sending reports, whether it's via fax
Yeah.
or email, text, they
Yeah.
appreciate that. And
Yeah.
or phone call. I think the phone call is always nice too. Like, what's going on with my patient? Because inevitably they will go back to their referring doctor for
Mhm.
glasses, contacts, for cataract post-op if it's an MD that's referring them to us, and they
Mhm.
want to know what's going on and be involved, and so they're not in the dark when they're talking to that patient.
Nice.
Yeah, that's important to keep the communication lines open and just be
Mhm.
really detailed with that. Looking on the other side of things, so for those ODs who offer advanced dry eye services like meibography, IPL, RF, what are the best ways to set up a referral system to inform other ODs and healthcare professionals of the services you are offering?
I think just networking, finding out who's in your area, going to some of these meetings, your local society meetings, and letting them know, hey, are you treating patients for dry eye? How are you treating them for dry eye? What devices do you have diagnostically and therapeutically? And if they're not embracing some of these newer technologies, that you're there to support them. Or we've had some instances where I'm going to these events and I see one of the patients who comes from my colleague, and I let them know, hey, we're taking care of this patient. If there are other patients who are more challenging or clogging up your schedule, send them our way. And that could be difficulty personality wise, or patient has a lot of questions, or their case is just really challenging. Oftentimes when these patients come in to see us, we're their fourth, fifth doctor if they're finding us on Google and they've lost hope.
Yeah.
Some of them are depressed, suicidal,
Mhm.
and it's really, they're very frustrated. And so they're just so happy to see us and look after us. And they go, how come my other doctor didn't tell me about this? And one of my main philosophies is patient education and empowerment, and never putting down another physician healthcare provider. That's one of the big things I learned early on when I was in training, is to speak up on our colleagues. So karma will come around and bite you.
Yeah.
Even if that patient wasn't referred by another optometrist, it might not be a bad idea to send them a report and say,
Yep.
hey, who is the general optometrist? I'm going to send them a report. Because sometimes they tell me, I'm going to give them a piece of my mind. And I go, no, 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 no. Do it in a productive, constructive way. We never want to put anyone down. And in fact, if you don't mind, I'm happy to call them on your behalf or message them, let them know what's going on. So, because some of these patients come in and they have a lot. So we talk about ocular surface disease, not just dry eye disease.
Yes.
Mhm.
And the patient may come in and have Demodex blepharitis, obstructive MGD, ocular rosacea, nocturnal lagophthalmus, conjunctival chalasis, like lid wiper epitheliopathy. They might have 5 or 6 different diagnoses, and we have to address that individually. Just like the patient went in to visit their primary care or cardiologist, they may have hypertension, diabetes, high cholesterol, thyroid disease. Each of those treatments needs an individualized approach. Same thing. It's not just dry eye. Everyone's treated the same. We treat each of those patients as a different puzzle and challenge, and we have to customize their treatment plan.
So true. And I like what you said, where you're never going to put down another OD or another OMD for the treatments that they offer. I've also learned that too, because I do binocular vision assessments and I offer vision therapy. So there's always the conversations of some parents who come in and say, well, the other doctor said that my kid should just patch one eye full time, all day, even when they're sleeping, or they have like these really thick glasses. And, the surgeon said therapy doesn't work and he should only get surgery. So I don't know. I have to hold myself back, because even if I don't agree with, a treatment option another OD or MD is doing, you have to, if you show your kindness when you're talking to the patient, saying that, well, the other doctor is not wrong. There are just different ways to treat it. And, that was the way it was, a few years back, but now with more research coming out, there's newer ways to do it. And this, the patient sees that too. And then they trust you more, because they know that you're already being a kind person to someone that even the patient might not like agree with. They might not like that other doctor either, but you're the one being calm, cool, collective, and saying, no, 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 like everyone's right, but let's just go down this path and let's
different approaches. Let's take this approach. They tried that. They've approached it from the pharmaceutical perspective, or they approached it from a plugs perspective. Let's look at it a different way. And they didn't have all the testing. And the other doctor may not have had all these different devices or tests in a specific way. So we've done
exactly true. Yeah.
Some of these extra tests, just like your primary general practitioner will do certain tests, but I went in today and had a cardio stress test, right? So the primary care practitioner isn't going to have a stress test in their office, right? General optometrists may not have tear osmolarity or an oculus to check mybography and things of that sort. So
exactly.
Some of these patients spend an hour and a half in our office for their dry consult, because we're going deep into background and symptoms, contributing factors.
Yeah,
that's true. That's true.
The next question I have for you, Dr. Silani, is probably like the gold question that I think all, especially maybe young ODs or new ODs, have. So for those patients that show up with early or mild dry eye disease, with all the different treatment options out there now, do you recommend that we should maybe refer immediately and start those advanced treatment options to hit them hard and make sure it gets treated? Or should we monitor still with their home therapy and, the products that we offer in office?
So I think it also depends on the patient and how proactive and how important preventative care is. And I think the home remedies are great to a certain extent. It's like having a headache, and I take Tylenol once in a while. Now, if they're taking artificial tears once in a while, they're using a compress once in a while, that could be okay. But if they're noticing that their contact lens discomfort is an issue, their eyes are watering all the time, they're having to use lubricating drops like candy and taking them all the time, that's kind of like a Band-Aid. And we need to take, it's like taking Tylenol every day. So that's a good idea to kind of pass them off and see what's going on. And especially if that general optometrist is trying every single daily contact lens, the patient is not happy in Dailies Total One, Oasis One X, My Day, etc. It's not the contact lens.
Yeah.
It's the ocular surface at that point.
But they always say it. They always blame the contact lenses. I can't wear them anymore. It's not good.
Or the other way around, right? They go, yeah, I'm comfortable in my contacts. Well, how long can you wear them for? 4 hours.
Yeah.
So that's
okay.
So I think digging a little deeper is, so we might think is mild or earlier onset. And then we do myopography, we go, wow, their glands structurally are pretty beat up or damaged, and they might actually fall into the moderate or severe category. And some of these patients actually appreciate, even if their glands have some mild changes, being sent out, doing treatments that are addressing the root cause, which can improve their quality of vision, can improve their contact lens comfort, prevent them from developing styes. So one of the main things that even general optometrists may benefit from is giving a patient a standardized dry eye questionnaire, even at a comprehensive or contact lens evaluation, just to get a gauge of what symptoms they're experiencing, what they don't like about their glasses or contacts, what time of day, if they're experiencing dryness, is worse, morning, afternoon, evening, middle of the night. They might have lagophthalmos, asking questions like if you're checking their lids and lashes and you're seeing that there's a lot of lid laxity, and they may be a little bit wider individual or patient. If they have sleep apnea, are they sleeping with a sleep apnea machine, and is there that upward airflow? Do they have a fan that's directed towards them that's contributing a lot of issues? And sometimes it's an easy fix of, here's a nighttime therapy option like an ointment or a goggle, and that can give them tremendous relief. But yeah, certainly if there's any level of dryness, it can't hurt to send them out just to reinforce as well as solidify if they really would benefit from office-based treatments. Because my patients see that, they go, man, I wish I would have came sooner, or if I would have came sooner, can I protected these glands that maybe permanently?
And that's why I asked that question too, just because when I've referred patients, eventually after they've tried all the products that we have at the clinic, some of them say that and they go, I wish I knew about this a year ago, 2 years ago. So that's why I was very curious to know if we should just start having those conversations right when we diagnose them with dry eyes to say, you know what, there's some more advanced options to start with rather than waiting. But your answer was great. It makes a lot of sense.
And I mean, we all know it's so much easier to treat patients that have actual dry eye symptoms. But speaking of more difficult kind of patients, how would you educate asymptomatic patients with signs of dry eye during their comprehensive eye exams to seek further care with an optometrist that specializes in dry eye?
Yeah, so similar kind of idea, the signs, symptoms, right? So signs precede symptoms, and the patient who develops a cavity may not feel the cavity, but we want to take care of that early on so it doesn't lead to something more serious. It's usually more cost effective when we're getting things earlier on rather than later in the journey. And so those patients, we can try to improve the frequency and severity of their symptoms, or even the onset of symptoms if we tune into that early on. But I'm hoping that down the road, more and more general optometrists will embrace simple things that can be done, like vital dye staining. I think is an easy, inexpensive option. Put in some fluorescein, put in some lissamine, although lissamine is on back order at the moment and hard to find here in the States. So rose Bengal can be an alternative. Lifting the lid and pulling to see if there's any kind of Demodex or collarettes on the base of the lashes. So some of these patients with Demodex go, I don't feel anything. But then once we go to treat them or we perform a BlephX treatment, they go, wow, this is what I should feel. This is what I should be feeling. And so some of these changes happen so gradually over time that it becomes a new norm. Whereas if it's a sudden onset, the patient goes, oh, I had LASIK and my dry eye happened, or I started Accutane and my dry eye happened, or I started this new medication, or I was diagnosed with a certain health condition, or I got COVID and I have. So when it's a sudden, it's an easier diagnosis, but when it's a gradual over time, it can be missed by the patient and sometimes by the practitioner. So we try to spend a little longer with them to see, even at a comprehensive exam, if they're not coming in specifically for a dry eye consult and they're seeing my colleague, she might transfer them from a comprehensive visit to a dry eye visit just based off of the conversation they're having or what they filled out on their SPEED or OSDI questionnaire.
Oh, wow.
Yeah.
It's funny you said that because I think the first time I ever experienced what real moisturized eyes feel like is when we started practicing with scleral lenses in our lab at ICO in optometry school. We put those scleral lenses on and I started blinking and I was like, but I can't feel my eyelids blinking anymore. Like I feel hydrated. Like this is what it's supposed to be like. And everyone was like, yes. And I'm like, but I feel the friction all day, like on my eyelids, but I just thought that was normal.
Yeah, a cool
You
tip.
should just wear sclerals all day.
I know I need to. I know. I'm the worst dry. The doctors are always the worst patients. I am the worst dry eye patient. I don't follow any of the protocols. I just deal with I'm just waiting for the neurotrophic keratitis to come through so I don't feel it anymore.
My wife has to push me to go to my doctor visit. So I get it.
Yeah.
That's what I mean. It's hard. It's hard. You have to try to convince yourself before you'll be able to convince your patient, right?
Right.
So true. When we're talking about relieving dry eye symptoms, let's just talk about your clinic and all the cool technologies that you offer. So out of all those treatments like, RF, iLux, IPL, tear care, LipiFlow, and probing, have you found that there is specific technology or like a combination of therapies that you've noticed to work really well together in bringing relief to certain types of dry eye issues?
We're honored that we have patients that seek us out from out of state or out of town, and they're here for a limited time period, and we do our best to do what we can locally and then try to pass them off to another dry eye specialist in their area. So when they come in, we tell them, we properly identify, diagnose, and come up with a treatment protocol. Some of these patients like, yeah, let's go all in. Let's do combination therapy. And so from some of our local patients, as well as out of town, out of state patients, we've noticed that the combination therapy is quite effective if there's multiple things going on. So what I mean by that is if they have, and I break it up into different categories, if they have anterior blepharitis or even posterior blepharitis, like a capped gland, LWE, they might benefit from a microblepharal exfoliation, such as BlephX or Zest. If they have some sort of obstruction where their glands are inspissated, toothpaste-like, their non-invasive tear breakup time or tear breakup time is reduced where they are showing signs of evaporative dry eye, we will certainly lean into the thermal heat expression pulsation devices. If they have more of an MGD rosacea component, inflammatory lid issue, lid vascularization and telangiectasia, we'll lean into a light therapy option like low-level light or foundationally OptiLight IPL by Luminous has been a big driver in our office and given a lot of patient success. We typically see from the literature that it can take 3 to 4 visits to see an improvement with things like OptiLight, but boy, we've seen some of these patients after just one session, 90% improvement, 75% improvement, which is fantastic. We let them know that's not the norm and not what we expect. And just like if you're on antibiotics for an infection, you want to continue the course. The same thing, you want to continue those 4 visits, you want to lock in the benefits. And once they're out of the rehabilitation phase, we can pivot into a maintenance phase. So scleral lenses may be a great option for some of those patients who aren't responding to these root cause treatments, or probing might be a great option down the road if they're not doing so well, if the inflammation is really long-standing and there's fibrosis or scarring inside their gland. So the cool thing is that we can kind of pivot, right? If they have epiphora, dilation irrigation is actually a great option, right? They either have dry eye, they have a blockage in their nasal lacrimal duct, or they have some sort of allergies. And so we want to address each of those things.
And when you're talking about the maintenance phase, are you just talking like, continue the home therapy treatments, or is it more like continuing more of those advanced treatments? And
So
how long would you wait until you would, like, once you're done the 4 treatments, how long would you wait to do another 4, or would you just do 1?
So great question. So both. We want them
Okay.
continuing their home routine. If compliance is difficult at home, and we all know how difficult warm compresses are and how time
Yeah.
consuming that is. And so that's the one to go the easiest.
Yeah.
Other things like Avenova spray, usually pretty compliant, or foams, wipes, things of that sort. Omega-3s, not too difficult if they leave the bottle close to their other vitamins they take in the morning with food. And lubricating drops, as needed, hopefully. So our goal is to try to get them usually off of like an immunomodulator pharmaceutical,
Okay.
as well as try to minimize their dependency on lubricating drops. So that's kind of what I mentioned to them earlier on. Now, if they have an autoimmune condition like Sjogren's, it may be trickier to get them off of a lubricating drop forever, but we want to try to manage their condition as best as possible. Now, when they go from rehabilitation phase to maintenance phase, hopefully they're continuing the home remedies, but the office-based treatments we may want to continue with, and depending on the severity of their condition, the more severe patients, we might keep that interval shorter. The more moderate patients, we might spread that out a bit, and the more mild patients, further out. So as an example, after the first 4, that severe patient may be seen 6 to 8 weeks out, that moderate patient may be seen 3 months out, and that mild patient may be seen 6 months to a year out. Now, some of these patients, there's no harm if you close the gap or you want to see them more. And they also appreciate some of the aesthetics, which we can talk more about too.
I know.
So,
that's the most exciting part.
Well, yeah, speaking of aesthetics, I mean, and even your clinic being located in Beverly Hills, how can we not talk about that? Does your clinic incorporate aesthetic services, since so many of these like dry eye and aesthetic services overlap? Do you guys do that now or planning to?
Definitely crossover. At the moment, we don't specifically see patients for aesthetics only. We do see them for dry eye, but we highlight the benefits of a positive side effect that may have aesthetic benefits. So the 3 main ones that we have in the office that have dry eye benefits are the radio frequency. We're currently using Luminus's option. The IPL, the Opulite, which is Luminus's option. And then we have low level light therapy, which is by another company called MD Elite. They're all great, effective solutions for managing dry eye, but they also have some aesthetics like collagen strengthening, lifting, tightening, helping against sunspots, things of that sort. So we'll customize it depending on what the patient, when we're doing treatments, we will highlight what specific aesthetics they might be getting in addition to that. And we've seen some of those benefits. And I'm, as a dry patient, I also appreciate the aesthetics and staff. So.
You got to get ready for that new baby.
Yeah. Right.
You got to keep it tight. Yeah.
I'm sure other ODs that are offering advanced dry eye services are always thinking about that in the back of their mind. When do you decide, or what factors make you decide whether to bring in then that full aesthetic service? What would convince you to say, okay, maybe now's the time we should bring in an esthetician and market it for aesthetics as well?
We've had patients who were in that area, right? The lids, the eyebrows, the temples. And so they asked, do you do fillers and Botox and things of this sort? And I'm always cautious because Botox in the crow's feet area can actually contribute to dryness. Like lash extensions can contribute to dryness. So when we're talking about aesthetics, we're not just talking about devices, right? We're also talking about makeup and things like Upneek to widen their eyes and give them a bigger fissure size and lift that blepharoptosis. Even VUD eye drops to help them be free of glasses, right? So that way they can go out there and look young when they're going to dinner and not feel like they have to put on these old reading glasses. So yeah, we certainly do some of those other things too. We do offer those services and to prescribe them Upneek, VUD, cleaner eyelid, makeup like Eyes of the Story, or there's another one called 20 Beauty, and others, of course. We want to make sure to avoid certain toxic ingredients in their cosmetics, even their facial cleansers. That patient tell me, yeah, I switched a new facial cleanser and I was having a lot of irritation. I had a older patient of ours who mentioned she started using a new nail polish and that caused some sort of eczema-like symptoms. She stopped using it and it went away. So paying attention to your patients and what new products, what new foods they're eating, that can play a big role too in helping manage their life. So we're kind of like a functional medicine meets dry eye aesthetics center. And we may lean in further into some of those procedures in office, but I think we're going to wait a little longer on that. You know, if we bring in another, I think a good time for us would be if we, especially if California has some interesting rules, is bringing in an MD and creating like a dry eye / med spa.
Oh, okay.
So that the dry eye patients keep us busy and we love them, and it's really gratifying. It can be very intensive on our team, but just like vision therapy, we can see some really great results, and patients who are very grateful for restoring hope, especially if they've lost it or gone down the path. I mean, some of these patients, a loved one brings them in because they can't drive, they can't work, they have to wear sunglasses indoors. Some of them are already on a leave of absence because their dryness bothers them so bad. I have a patient that we're managing with their psychologist because she really thinks that she's going to be one of these patients she's 28 years old, 28-year-old female patient, Caucasian, who's going to have to listen to podcasts and audio tapes and not going to live the rest of her life using her eyes appropriately. And so, yes, if left untreated or mistreated, certainly dryness can lead to a lot of light sensitivity, eye pain, keratitis, scarring, vision fluctuation, and blurriness. But our goal is to try to reel them back in and not go down that mental play, that bad place mentally.
Yeah. And I think that's the best part. You know, like you said, you can always include aesthetic services or nutritional services. I mean, you could do so much more with the specialty dry eye clinic, but it's always that fine balance. Like the more, you know, hands you put in other cookie jars, you know, you're stretching yourself thin, and sometimes you dilute the care in all those services. So if you just stick with that just dry eye specialty area, then you can spend more time counseling your patients and just focusing on the therapies too. So I guess
and
that's true.
Well, this conversation is just what you said is so important, because referrals, right? What we're talking about is referrals. So I get to a point, I go, hey, you have allergies. I'm going to send you out to an allergist that we work with closely. We need certain blood tests to make sure you don't have. I had a patient recently, she came in, she looks so healthy. She's in her mid-30s. We had her tested for inflammatory markers, liver enzymes, kidney, the whole gambit, cholesterol, thyroid, and vitamin deficiencies. She came back with alerts on her blood tests. Her liver functions were off the charts. Her cholesterol was off the chart. Her ESR and C-reactive protein for inflammation was off the chart. So we're like, okay, I can only do so much. We got to get you in hands of somebody who can help, a functional medicine specialist who can help me manage some of these things. Because, you know, my specialty is dry, not all these other symptoms. So we got to get somebody else to be the quarterback for all these other issues we got to manage. So, and she was so appreciative. Going back to, I was helpful in getting her a solution, pointing her in the right direction. So going back to the whole idea of having eye surgeons or general optometrists referring to their colleagues in eye care.
Well, if you ever do bring aesthetic services, I will fly down and I will be the guinea pig. I don't mind. I only take Starbucks gift cards as rewards, so it's okay. I'll take $5, $10. It's okay. I won't ask for much else.
One of my favorite things is gland expression. That pimple popping is really oddly satisfying. And we were invited onto the doctor show to perform was tear care with meibomian gland expression.
That's
and
so
that
cool.
moment when the audience was like, ew, I knew I did my job to represent optometrists nationally and internationally.
I think that's my favorite part too. When I do the expression and I'm so excited to show the video to the patient, I'm like, okay, are you ready? This is how it looks. And I have like this huge smile on my face and they're like, oh my God, you actually like watching this? I'm like, yes, I love it. Do you love it? Do you love it? And they're like, no, don't ever show me again.
I get some who freak out like that, but I get others who want to take a video and show their loved ones and love it. I go, yeah, absolutely. And let me record it for you.
I feel like it would be very, very difficult to offer dry eye services without an anterior side camera like that. Like when we talked about, you know, how do you educate asymptomatic patients? Like that Demodex and that rosacea on the lip, that's all you need to show them. Even that oily tear film, and they'll be like, I'm sure once you have the camera, you don't need to convince them otherwise.
Yeah, and we touched
So
on
easy.
technologies on the therapeutic side. You're
Yeah.
right. We touch on technologies on the diagnostic side, and
Yeah.
so it can be low tech or high tech. And of course, we decided to choose the high tech route. And we still do, the traditional conventional things like vital dye staining, but the Firefly slit lamp has been so helpful to connect
Yeah.
the dots to patients when you're able to image those different conditions, all the keratitis, show them the before and afters. Even if you have the collarettes, the patient has the collarettes, and we do a 10-minute, 5-10 minute BlephX treatment, and we show them immediately afterwards that it's basically gone for today. And it can come back, but it's gone for today. And foundationally, we got rid of the plaque, the tartar, the biofilm. Now go home and continue your home regimen. That goes a long way. And even showing them on the keratograph, we love the full suite of here, patient, I'm going to show you the tear meniscus height to check for aqueous deficiency, and the non-invasive tear breakup time to show them what areas of the tear film is evaporating quickly with the software, showing them the telangiectasia, showing them the meibography images, and comparisons against normative data or abnormal patients. That's just like a big wow factor. And how soon can we get started? And I want to take care of this right away. Because what we do is so visual, and so many patients are visual learners. So to be able to demonstrate that to them and connect the dots once again is really powerful.
Yeah. We got a slit lamp with the anterior side camera on it too for a new private practice. And so even for me, someone who doesn't offer the advanced treatments, having that camera is going to make it so much easier for me to encourage my patients to go to that referral, right? Because, and even the Google ones, they just don't do it. I mean, the patients will look at it and go like, okay, but when you can show it's their eye, I think for us ODs who need to refer out, it's also going to be so much easier convincing them that just go to this specialty OD. You're going to get the best care. So I'm excited to use ours too when we
Well, I
open.
love that you're involved in vision therapy, because it's something that
Yeah.
we'll see and we don't really do. And so we refer out to our optometry colleagues for vision therapy as well, or neuro rehabilitation services, neuro-optometric rehabilitation services. So
Yeah.
I think it's awesome. I think it's so great that we can all work together and refer to each other. And I think that's only going to continue. Where we were when I was doing this 10 years ago or 5 years ago, and where we are now is
So
absolutely
different.
incredible.
Oh, it's so crazy. Yeah.
Even the referring optometrist, like, hey, what new products are you recommending to patients? Or can you let me know what you're going to switch them to? So I'm sure that I'm involved in that. And why are you putting them on these different things? And so, my philosophy, again, patient education empowerment, but also colleague education empowerment, whether it's speaking on a podcast or, on a podium or webinar.
Yeah.
I'm so curious just to know how you feel that perception of like dry eye OD to OD referrals has changed in the last 5 years or so, because I feel like your journey and almost like Dr. Richard Maharaj's journey are kind of like the same. Like you guys started your specialty clinics non-dispensing dry eye only like about 10-ish years ago. But I feel like only now in the last few years dry eye topics have just exploded. So how was that referral system like, when you first started out for the first couple of years? Like how many people were referring to you? How hard was it to get people to come in?
Great question. So early on, I was super excited about the treatments, and I brought in those, and the conversions weren't really that great.
Yeah.
Brought in the diagnostics and able to educate them properly and show them what was happening. And then I think it became an easier conversation. But we're light years ahead of where we were 5 years or 10 years ago. I think just the education of the companies that I've consulted with and have been on their medical advisory board, just reminding them, you guys have the deeper pockets. You guys need to help us educate direct to consumer. And Luminous has listened. We've used their technology for 6 years, M22 and the Optilight. And so they brought in Manji Moore, and we got to work with Jenny Garth and Ashley Tisdale, and we see celebrities coming into the space with one of the Jonas Brothers and Evo ICL, and Whoopi Goldberg talking about her with cataract surgery and how she's now independent of glasses. We see that with Jennifer Aniston and Ken Jeong with some of the pharmaceuticals of dry eye. So
Yeah.
I think some of these patients becoming vulnerable and sharing their stories and becoming the face for dry eye has helped to make it an actual disease and less of a nuisance or inconvenience. And
Yeah.
with patients too, and I go, there's no shortage of patients for dry eye. There's just a huge shortage of doctors to treat these patients. So that's why, for me, I want to encourage as many doctors as possible to get involved. Just kind of, if this topic is something that you're passionate about, I would consider or urge you to enter the advanced dry eye space. Again, there's a huge shortage of doctors to patients. So just keep in mind that these patients require and deserve a lot of ongoing attention to manage their condition. So there's going to be a lot of ups and downs if you decide to go into this space, but really at the end game or the ultimate goal is to try to improve their quality of vision and their quality of life. And extremely satisfying, just really, really something special. And these patients become our raving fans and they refer their network of patients. And just like when we send patients in for LASIK surgery, they tell their friends. And so, it's a wonderful, wonderful thing. So whether you're going to refer, those patients are going to love you and become loyal to your primary eye care office. And if you're going to get involved and actually treat these patients, they're just going to love you because of the relief that you're able to give them and just the hope and give them back their lives.
Thank you again, Dr. Silani, for coming on. We're so happy that you're finally a guest on the 4Eyes podcast. We'll leave your information for everyone to reach out to you and your clinic if they have any questions. And yeah, just thank you again. Congratulations on your soon-to-be baby. Congratulations on the 10-year anniversary. Wishing you a good luck for another 10 plus more. And by that time, we will be there for the fixing the crow's feet and everything.
Thank you so much, and really appreciate what you guys are doing here, and love the podcast. And you have a fan and a follower moving forward from the past, but also moving forward.
So thanks for listening to 4Eyes, the podcast series brought to you by YoungOD Connect. Be sure to subscribe and follow us on Instagram or YouTube at 4Eyes Optom for more content. We'll see you guys next time.
Bye.